France, and the title of his talk is about what is the best chemotherapy backbone to targeted therapy in metastatic colorectal cancer. Professor Igiloc.
Salam alaikum. That's all my Arabic. I want to thank the scientific committee for inviting me to give this talk, since even though we have made progress with targeted agent, still chemotherapy backbone remains the most important part in the treatment. So a few things that I will briefly review are well established. We know that in the first line at least, and maybe second line, FOLFIRI and FOLFOX didn't show much difference. This was demonstrated by Christophe Tournigan about more than 10 years ago, but the drugs have different toxicity profile. It has been also repeatedly demonstrated that Igiloc is very similar to FOLFOX in terms of outcome. Similarly, with fewer studies, however, and mostly in Europe, FOLFIRI can be used, but Igiloc can be used as well. And more recently, the Italian group GONO has demonstrated that chemointensification with the triplet FOLFOXIRI is superior to FOLFIRI, and honestly, to me, this was not a surprise. So this was the design of the initial sequential first and second line FOLFIRI, FOLFOX, or FOLFOX, FOLFIRI. You have seen that before, and just to remind you of the outcome, you see that the response rate, stable disease, median time to progression or median survival showed absolutely no difference whatever the sequence, and also whatever the choice in first line, and both drugs work similarly. However, there are differences in the tolerance profile, with more myelosuppression with oxaliplatin, more upper GI toxicity with irinotecan and febrile neutropenia. Diarrhea, surprisingly, showed absolutely no difference between FOLFOX and FOLFIRI. A little bit more mucositis with irinotecan, as well as alopecia, but of course the neurological cumulative toxicity, which is a limiting phenomenon for the prolonged use of the drug. The study comparing Igiloc and FOLFOX, we have two. One that was performed in France and published 3 years ago, and you can see on those curves that both from progression-free survival and overall survival, there is absolutely no difference, with hazard ratio very close to 1. Similarly, in the NO16966 study that was sponsored by Roche, it was a study done in 2 steps because of the approval in 2004 of bevacizumab, but they first started to compare Igiloc and FOLFOX, and then they added bevacizumab in a factorial 2x2 design. But whatever the combination used, FOLFOX or Igiloc, you see that the curves are superimposable in progression-free survival, and the final survival analysis was published 3 years ago in the British Journal of Cancer and showed absolutely no difference. And clearly, we can substitute Igiloc for FOLFOX or the reverse as we like. Now, FOLFOXIRI. This first study was published in 2007, and we have to pay attention that the FOLFIRI they used at this time was the initial FOLFIRI that I had the privilege of publishing. I won't tell you how many years ago, because this makes me feel very old. But this was a FOLFIRI with 180 milligram of CPT11. Then we had 2 boluses, day 1, day 2, and 600 milligram of infusional 5-FU over 22 hours, which is not what we do now. So you have to keep that in mind, because the FOLFIRI study initially was not using the best FOLFIRI regimen. Anyway, it showed that there was an improvement in response rate with a triple combination as compared to FOLFIRI, 60% versus 34%, increased resection rate also, and as well a benefit on overall survival. So chemointensification may work. Now, let's look at what is the best regimen to combine with the targeted agents we have, and first start with anti-angiogenic. I have focused my talk because of time limitation on first line, and we'll try to review the first pivotal trial that allowed registration of bevacizumab, which was the IFL trial, a bolus weekly regimen of irinotecan, 5-FU, and leucovorin with or without bevacizumab. This study was clearly positive on all endpoints, median survival, that was a primary endpoint, but also progression-free survival and response rate, as you can see from these data. However, this regimen was toxic, has almost never been used in Europe, and I think is no longer used in most of the institutions. Based on toxicity, a second study was performed by the Greek group using a modified IFL, lowering the dose of irinotecan and administrating the regimen only every 3 weeks. And with this modified IFL at lower dose, you see that bevacizumab was not contributing at all, neither on response rate or overall survival. So the initial Jurwitz trial with an IFL regimen, which is not feasible because of toxicity, was not confirmed by the Statopoulos study. Now let's focus with a combination of oxalic-based chemotherapy, again with the design of this Roche study. It turns out that the benefit of the addition of bevacizumab to either FOLFOX or Igiloc, and it is split in the various groups here, is not really impressive. There was an overall benefit, as you can see on the right part of the panel in red, on progression-free survival, which was only 17% reduction of the risk of progression, and this on the left panel was essentially driven by Igiloc. There was no benefit from the addition of bevacizumab to FOLFOX on progression-free survival, and the overall survival was not improved. There has been some further analysis looking at treatment duration, reason for discontinuation, but overall in the intent to treat population, this study failed to demonstrate an overall survival benefit. Now, if we look at the use of bevacizumab with our two favorite regimens, FOLFOX or FOLFIRI, this was done in this Italian study of 370 patients. They were randomized to either FOLFOX or FOLFIRI, and you can see that it was an investigator choice, and the ratio was 60% FOLFOX, 40% FOLFIRI, and the primary endpoint of PFS was not met. Actually, here again, adding bevacizumab to either FOLFOX or FOLFIRI did not significantly improve PFS with a hazard ratio of 0.86. That was not significant. Response rate was not improved, and the overall survival was a little bit more in favor of chemo alone. So actually, this raises the point that since the registration of the drug, we have had multiple trials, and none of them confirmed the outstanding effect of bevacizumab added to IFL. And when we look at the outcome according to chemo backbone in the ITACA study, you see that there is a trend in favor of better efficacy of FOLFIRI bevacizumab, but this is not reaching statistical significance, probably because of the low sample of patients. But again, the contribution of bevacizumab to FOLFIRI or to FOLFOX, to my understanding, needs to be confirmed. Looking at chemo backbone, I mentioned that we use quite a bit of auxiliary in Europe. We don't have a study comparing FOLFIRI and auxiliary, except one small German study on 40 patients. That's very hard to conclude. But if we compare in this Mexico study FOLFIRI bevacizumab to auxiliary bevacizumab, you see that in terms of response rate, it was identical, 53 and 54%. Median PFS, 9 months, for both regimen, and overall survival in median 23 months for both. So there is no difference if we substitute auxiliary for FOLFIRI. This is another study comparing K-POX. They call it K-POX in Germany, we call it Igiloc in France, but it's about the same. K-POX bevacizumab and K-PIRI bevacizumab. Here again, no difference. Both regimens behave exactly the same, and this is of course not addressing the contribution of bevacizumab, but Dr. Schmoll will address this question in the next topic. We have one head-to-head comparison of FOLFOX bevacizumab versus FOLFIRI bevacizumab that was recently presented, not published yet, by the West Japan Oncology Group. Please notice here that the dose of irinotecan they use in Japan is inferior to what we use in Europe, 150 rather than 180. But based on that study in Japanese with these doses, both FOLFIRI-Bev or FOLFOX-Bev behave the same. You see the hazard ratio, non-inferiority is demonstrated for PFS, and that was the primary endpoint of the study. And in terms of overall survival, which was a secondary endpoint, you see that there is no difference with the hazard ratio of 0.90. So it seems that whatever we use FOLFIRI or FOLFOX, the outcome will be the same. If we focus on the various chemotherapy backbone with bevacizumab, Eurovitz was IFL, Cabinevar 5FU, SALTS was the FOLFOX or Igiloc, Passadi was either one, Statopoulos was modified IFL, and there was two smaller studies with mitomycin. You see that in most of the cases, whatever the chemo backbone, then there is not a clear benefit of the addition of bevacizumab except from the Eurovitz study. TRIBE, chemo intensification, we have seen the initial trial. This is now the combination of FOLFIRI or FOLFOXIRI-Bev, but here they are using the contemporary FOLFIRI, the one with a single bolus and 2,400 milligram of infusional 5FU, which is a double intensity as compared to the first FOLFIRI. And here again, they confirmed that with the addition of bevacizumab, FOLFOXIRI is superior to FOLFIRI, both in terms of progression-free survival, response rate, and overall survival. So those data are very similar to what we have seen without bevacizumab, and I put side by side the study. Remind you that the first FOLFIRI was the old version, the second one is a new version. If we do cross-trial comparison, it seems that there is a better outcome if bevacizumab is added, but again, the control arm was not the same. We are now 5 years later, patient selection may have changed, imaging may have changed, so it's a bit hazardous to do so. But again, FOLFOXIRI-Bev is also a working combination. So based on the data we have here, Igiloc, FOLFOX, auxiliary FOLFIRI may be used with bevacizumab in terms of tolerance. Both infusional 5FU and oral capecitabine can be used, and FOLFOXIRI is superior to FOLFIRI. However, bevacizumab, as in comparison with chemo alone, has been evaluated in a very small number of studies, and with the exception of IFL, none of this trial has provided convincing data about the contribution of bevacizumab. Let's move now to the anti-EGFR therapy. Here the results are a lot more consistent. These tables show you the three main randomized trials, the two in green with cetuximab, either combined with FOLFIRI in Crystal, Opus in FOLFOX, Opus is only a phase 2, and panitumumab FOLFOX in the PRIME study. And you see here that we constantly have an improved response rate, which is consistent between 60 and 66%, improved PFS between 10 and 12 months, and improved overall survival. So these studies are very consistent. We know now that the population to treat are the RAS wild type on exon 2, 3, and 4 of both N and KRAS. We have data also with panitumumab and FOLFIRI that we didn't have before. This is a small single-arm German trial, and here again it showed that in the wild-type RAS there is a 59% response rate. It does not work as well in the mutant. And if we look at PFS, again, with FOLFIRI, we are in the range between 10 and 12 months PFS, exactly 11.2, with a good discrimination between wild-type RAS and mutant RAS. So with all these data in mind that were presented at the EMA, FOLFIRI has been approved in first line with panitumumab, so now we have the choice of the chemo backbone and we have the choice of the antibody. And similarly to what was done with bevacizumab, the PLANET study from the TTD group in Spain has compared panitumumab FOLFOX to panitumumab FOLFIRI, and you see from the table that the progression-free survival is not different between the two arms. The median overall survival is not different between the two arms, even though there is a potential benefit with the FOLFIRI, and the response rate in this patient with liver-limited disease was between 73 and 78%. So whatever you use in terms of chemo backbone, you may expect the same outcome with panitumumab, FOLFOX, or FOLFIRI. There are differences in tolerance here again, and if you look at myelosuppression, like neutropenia, it's higher in the FOLFOX arm than in the FOLFIRI arm. More diarrhea with FOLFOX panitumumab than FOLFIRI panitumumab. More asthenia, and of course, as expected, the neuropathy and anorexia. So it seems from this Spanish data, this was an independent study from Spain, that the tolerance profile of FOLFIRI panitumumab is better than FOLFOX panitumumab. An important point to consider when using anti-EGFR is the choice and the mode of administration of the fluoropyrimidine. I have listed here on the top oxaliplatin-based regimen in OPUS Prime and the patient from COIN who were treated with FOLFOX cetuximab. These were the initial KRAS exon 2 wild type, and you see from the three first trial that there is clearly a benefit. The future trial was a comparison of FOLFOX cetuximab to UFOX cetuximab. UFOX is UFT oxaliplatin, and it is in favor of using FOLFOX rather than UFOX. On the second part of the slide, I have listed the Igiloc use of those drugs, and you see that in COIN, when Igiloc was used rather than FOLFOX, the benefit on the KRAS wild type disappeared. The hazard ratio was 1.02, and if 5-FU was used as a bolus and no longer an infusional 5-FU, as they did in the Nordic 7 with Flux, again, the benefit is lost. So the evidence we have now is that the anti-EGFR may not work except with infusional 5-FU, and certainly oral fluoropyrimidine and bolus 5-FU should not be used. Similarly, there was a German AIO study looking at Kpox on the right part of the graph and KPRE on the left part of the graph. The wild type are in blue, the mutant are in yellow, and you see that if you use KPRE of Kpox, the discrimination of the efficacy between wild type and mutant totally disappeared. So here again, it seems that the anti-EGFR do not work with oral fluoropyrimidine, here capecitabine. So just to conclude on the anti-EGFR, of course it is restricted to RAS wild type. All the trials are very consistent. FOLFOX and FOLFIRI outcome are improved, whatever the antibody used on the main endpoint of the studies. And there is a non-inferiority when panitumumab is compared to both regimens. The patient selection is crucial again. Only patients with RAS, N, and K subtype exon 2, 3, 4 wild type are eligible, and the detrimental effects have been constantly reported with FOLFOX if a mutant patient is treated, whatever the mutation. The choice, again, of the fluoropyrimidine is important. There is no benefit with bolus 5-FU. There is no benefit with oral fluoropyrimidine, and a possible detriment that we have seen in the UFT oxaliplatin trial. So just as a general conclusion, both FOLFOX and FOLFIRI can be combined with targeted agent with different intolerance profile. Oral fluoropyrimidine should not be used, the sabotage. Oral fluoropyrimidine should not be used along with anti-EGFR. They may be used with bevacizumab. The sequence of targeted agents seem to favor anti-EGFR at the present time, but more data needs to be done. What is important, time up, is that the patient receive all the drug during the course of their disease. This has been clearly established by Alex Grothy. It is not established yet for targeted agent, but it is important that they see irinotecan, oxaliplatin, 5-FU, anti-EGFR if they are RAS wild type, and bevacizumab. Thank you for your attention.
Professor Dillard, thank you so much for this presentation, and I think we have time for a couple of questions, and I can start by myself. So from your presentation, you've mentioned that adding bevacizumab